4. So welcome all to Scrutiny. Please note that the meeting is going to be recorded and it will be broadcasted via the local authority's internet site. So the images and sound recording may also be used for training purposes. So apologies for absence. Yes, and
I think Anne Councillor Ian Thomas.
Yes, we've got 2, so thank you so much for that, Councillor Richards. Any declarations of interest, please? No, so start with agenda item 3, which is the 6 goals programme of unscheduled care, and Councillor Julia Jenkins. I'll hand over to you. Thank you.
Thank you, Chair. It's the scrutiny report for the update on the 6 goals programme of unscheduled care, the summary report. Scrutiny Committee requested an update on the 6 goals of unscheduled care programme. This report outlines the relationship between hospital discharge and adult social care and the progress made. The report outlines the impact of the programme to date and the next steps and the relationship to other developments around integration. The recommendations are the scrutiny note the contents of the report. Thank you, Chair.
Thank you.
Sorry.
Yeah, thank you.
Okay, thanks very much. I anticipate you've already had the opportunity to actually look at the report. The first couple of sections up to 3.3 should be familiar from previous reports that have been submitted to scrutiny, outlining what the role of the 6 goals of unscheduled care is. But essentially, the programme is to look at opportunities to prevent people needing to go into hospital through alternative mechanisms in the community, and when they are in hospital, what support can be provided and how people move through the system. You can see in section 4, it actually outlines then where we were. We've seen a significant increase in pressure across the system in health and social care for a number of years, and previously we would have seen, you know, specific issues at the winter period, but now those pressures are seen throughout the year. And currently, as of yesterday, Cwmtaf on the weekend went back into business continuity, so we're talking again going into spring season. So it's like there is no current, you know, winter pressures versus the rest of the year being, you know, sort of much easier. It continues along the same point. 4.3 indicates that we had no real clear plan for how we're going to deal with these pressures, and now we're looking at the priorities of further faster and the 6 goals. We've already done significant work in terms of the 6 goals, which will be, you can see in 4.4, which has been developing alternative routes to provide support in the community as opposed to attendance at the emergency department, more efficient use of the time that someone is in hospital to reduce the time that is spent in hospital, and developing support services for people to return home. 4.5 indicates, you know, where some of the work that entails, which is development of an electronic referral form that is sent from health to local authorities, development of a primary care navigation hub, development of a one list app, which is where people can see the same information on an individual whilst they're in hospital, so social care can access that, and development of an acute frailty model across CTM. We can see there's some on occasions where some of these have taken place in isolation, but the 6 goals programme is actually starting to join all those initiatives up to make it a coherent system-wide approach to change. Where we are now, as I said, we're still experiencing pressures across the whole system, and the example I gave was this weekend. And workers continue to focus on preventing people needing to be admitted to hospital and the improved flows with hospital and supported discharge, including discharge to assess. In terms of prevention of admission, one of the key elements there is the development of the primary care navigation hub, which allows GPs and other professionals to refer into, and then in 5.3 it indicates the support that is provided through the hub. And in 5.4, we also indicate then is the number of calls that have been going through the hub and the outcome of those. So they've had between January 23 and to date, so this was about a month ago when I drafted this, you can see they've had 5,517 calls, and of those 87% of those calls resulted in an alternative route to someone attending A&E, which is really positive. There's also been a significant amount of work in relation to improving flow through the hospital and onward to discharge. These have included the development and implementation of the supported discharge and discharge to assess team, which is part of Merthyr Adult Services and has been funded through the Regional Integrated Fund. And that became operational in December 23, and we're already seeing some impact from that team. The establishment of the Integrated Discharge Delivery Board, and that is comprised of members of each of the local authorities and health partners, that looks at the issues that have an impact on people flowing through the system and have overall responsibility for monitoring the Pathways Care Delay Action Plan. There's the design and delivery of the discharge to assess model, and work is ongoing with that. And we regularly monitor and review discharge data and the identification of areas for improvement. And what we're seeing now is at different times, the different key priorities that we're seeing in the region. We need to, as part of our group, they also monitor the pathway care delays action plan, which is submitted to Welsh Government on a monthly basis and monitored as part of that arrangement. 5.6 indicates that we're now aligning several initiatives to ensure there's more joined up approach, and one of the key areas for us at the moment is developing a community-based health and social care services and looking at a more integrated model that is in line with further faster. Where do we want to be? We want to be in a position where social care and health services work together to provide better outcomes for people, and we want to have systems in place across social care and health services to support discharges and prevent people remaining in hospital longer than is necessary. Section 7 then indicates our next steps. We know that the We Care campaign continues and ongoing to look at improving the number of people employed in social care, and the implementation of the real living wage across registered social care services continues. Next stages for the development of the primary care navigation hub are going to be enable same day direct emergency care, pathways for Welsh ambulance, trust to increase the number of cases redirected from emergency departments, continue to evolve and integrate with other communities' resources. And one of the things we look at going forward, it'll be how can we integrate with social care better in that area. Increase professionals' awareness of the navigation hub, so all professionals know that that is an alternative. The future vision includes further integration with other community resources, which includes collaborative working with local authority partners, and this will hopefully then develop into a single point of access for all our community resources, though this is not an immediate ambition, but that is one of the longer term aims of that. There's also an aim to mandate care homes contact the hub before contacting 999 unless it is deemed to be life-threatening emergency, and that's based on the fact that the involvement with care homes has had significant impact on people being able to remain in the care home rather than going into hospital. And there's been intention to further develop digital and remote services to provide patients remaining safe at home. Next steps, we'll be looking at producing a new discharge policy and toolkit that's based on the new guidance by Welsh Government, to embed the electronic systems for supported discharge, notification form and electronic transfer of care, to embed the use of the whiteboard system across the boards to make sure that the data that's on there is current, to finalise the community dashboard with live data on the current position and pressures within the hospitals, and to implement the trusted assessor model that we've commissioned through Age Connect Morgannwg. And this will be done. And the other thing we've done is appointed a regional director for integration who will be developing an implementation plan. So if there's any questions, feel free to ask.
Thank you, Angela. I'll come first to Councillor Tubby.
Yes, if people have chest pain and they ring 111, is that a part of this navigation hub, or is it just mental health?
Mental health, you can ring 111 with any sort of physical condition, and then they use an algorithm that takes them through. So if someone was saying they had chest pain, I think one of the first things to say is the algorithm would say you need to go to A&E because they can't diagnose whether there's a heart attack, as you like fully aware. But then what they do as well is like the new element on 111 is 111 press 2. Sounds a bit of a mouthful, but that is where you access all mental health services now in the community. So through that you can access crisis team. You can refer on to, like, if there's any emergencies, through the 111 press 2 for mental health. And again, they go through those questions and direct you to the most appropriate service.
Because this figures of 87% avoidance. If you're in A&E, you see rows of people referred by 111, and I find it hard to believe that they stop 87. They may tell people.
Hang on.
Yeah.
There's a difference between 111, which is the generic number.
Yeah, all right.
So that's the number that's out there. So if I rang and said, oh, I got a sore arm, that's open to the public. The navigation hub
That's separate.
is a professional, it's not open to public access. This is for GPs, and the other thing they've been doing is taking off the stack. So in the ambulance, when people phone through for an ambulance and they say they need an ambulance, it goes on to what they call stacks. All these names of everyone sit and they prioritise them, triage. So number one on the stack, so you've heard on TV, red, ambers, and so as they do it. So because they're based in the GP out of hours over in Tehilai, they can also see that live stack of all those people who are waiting for an ambulance to go and see them. You ring 999 and then they put the data, ring for an ambulance, they put the data into the system, and then that forms the Welsh Ambulance stack. I don't know how else to describe it, but it's a database of all the live calls that are there. Well, the navigation hub, primary care navigation hub, can do is look at those stack and say, well, we could be able to pay, rather than wait for the ambulance to go there, we could pick that up and we could arrange for someone to go and have a look at that individual.
Right.
Yeah. So this is all professionals can refer into. The GPs have been using it quite a lot. Welsh Ambulance have been using it quite a lot. So it isn't the total 111. God, if they only had 5,500 in the 111 service, they'd be thinking, God, this is easy.
Yeah.
No, this is only the navigation, community primary care navigation.
Oh, thanks.
And Owen Week has been taking the lead on that.
Yes.
Yeah.
Yes, oh, thanks.
Thanks, Councillor Tubby. Councillor Gareth-Richards.
Thank you, Chair. Bear with me a second, because I'm referring to questions that have been referred to me from Councillor Maynard Vokes. For me to be able to edit them as well, not edit them, but to understand what she's asking. It's around staffing structures, it is, Angela. I think we had an update on staffing structures, says in October. And the question is, has there been any changes to that since October that we were advised of? And are all the positions now filled?
The staffing structure has not altered to the one that was presented to scrutiny. Not all posts are filled. The two posts that are currently probably key posts that are vacant is the adult safeguarding team manager, which we're in the process of appointing, and the principal manager for assessment is currently appointed, and we're waiting for them to take up post.
Yeah, that's fine. Chair, I don't know if you want I've got quite a number of questions here from, if Declan wants to come in on any questions he may have, rather than me to org it all, or how do you want to play it, really?
No, Councillor
You can try and
Richard,
make ours.
no, I've got the questions in front of me,
Yeah.
and I think if Declan ends up putting his hand up at some point,
Right.
I'll just raise my hand to you and then we'll come back to you. But
Okay.
so far, there's no indication of
Yes.
Councillor Salmon going to speak,
Okay,
so thank
thank
you.
you, Chair, much appreciated.
Thank you.
The other is around admittance to hospital. And within 48 hours is a discharge pathway created. The question relates to who completes that and who shares it and how is it monitored?
Right. When you go into hospital, within 48 hours of you being medically optimised, they're starting to look at where you're likely to go when you discharge plan. So probably the easiest way to describe it, if you went in and you're having your gallstones out, there's a pretty clear pathway that is saying, right, you're going to go have your gallstones out, then you'll go home within X amount of days. Yeah. So something like that for a pre-elective planned surgery is really sort of quite straightforward. So that is determined by the ward team on what the pathway that you were going home. So the most obvious one in that one would be pathway 0, you'd go home with no further support from anyone. So it's actually looking at those that are likely to need a package of care and then starting that process rather than waiting until someone is all ready to go home and then think, oh, well, they need a package of care. So they're trying to start that planning and thinking much earlier in the process. So initially it's the ward-based staff and the consultants as part of the MDM, but with the supported discharge team now, they go into the board round, so they will have input into that decision making.
Yeah, thank you. Yeah. The further questions on paragraph 5.4 follow on for Clive as referred to is in relation to the 517. Is there any breakdown on demographics, Councillor Maynard Vokes is asking?
Is most of this is now data, this is primary health, primary care hub. I don't think I haven't seen anything with the breakdown of the demographics of those calls.
Yeah.
So sorry, I can't provide detail, but I will ask at the next meeting if that's available.
That's much appreciated. Is it okay, Chair, for me to go? A question in relation to 7.4, the contact when care homes are mandated to ring 999. Could you share any information of the rationale behind that? It sounds quite severe then, really, doesn't it?
No, I think what they plan on that is, say someone had a fall.
Yes.
Right, probably it's easier to give examples to illustrate what we're talking about. As it stands now, someone had a fall in the care home, first thing they do is ring 999, right? And then to see if they can come, right? But then in what they say now is that potentially they could see around the GP going to see them out of hours or be able to direct them to something else before that ambulance comes. Yeah. So it's more around just calling 999.
Yeah.
What they're thinking of is that quite often if they'd ring a GP, the GP will, one of the practices may say, oh, look, well, I can't come see him, just phone an ambulance and phone 999 and arrange for an ambulance to come pick them up and take them to hospital. So this is a way of trying to look at it as an alternative. Obviously, if someone's suffering, the example Clive gave earlier, if someone had severe chest pain, well, they wouldn't go to primary care hub. They'd be looking at ringing 999 because that's an acute emergency. If someone's unconscious or anything like that. But this is where some of the things that are called for 999, the chest infection, where someone is just unwell, is particularly unwell. So they're looking to see if they can do that. Because if you think of it, if you were in your 90s, you're not feeling very well, and then the ambulance comes and they take you off to hospital, waiting then for someone to come and examine them. They could be there for like several hours waiting. Whereas if the GP could do that from the navigation hub, could go and see that individual, they'd be far more comfortable in their own bed in the care room.
Yeah.
So that's the rationale behind it. It's not to replace super emergency stuff. it's more around some of the stuff that's going through 999
Yeah.
that could be better dealt with through an alternative mechanism.
A further question then, Andrew, if that's okay.
Lord, you've been busy,
Yeah.
Councillor Minnesota.
They're not all of it,
At
but
least
some of
you've
them are.
read
Paragraph 7.5 around the technology. What about those who are not technology, not able to use technology then?
Right. Some of this was developed during COVID, if you think about it, because people weren't able to, and we do it now as well, is where people couldn't attend GP practices and things like that. They looked at alternative mechanisms. So this is not one size fits all, as we know, and some people are never going to be using it. But if you look at it, some people now would rather have a virtual consultation with the GP or a medical professional rather than to go all the way to the surgery, sit there for half hour before their appointment. Whereas, for instance, if you work in, it could mean you could have your appointment to the GP without having to travel to go and see them. So it's looking at, is there some way to make it faster for everyone else? And it also means that you haven't got medical practitioners travelling around. So it's not going to be for everyone, but it is extending it so to see if it could better utilise people's times rather than doing it. So there's still always going to be that face-to-face option.
Yeah.
Because
It's for those who are able or want to use it then, really. Yeah. My final question here is in relation to paragraph 7.6. And it's the post that has recently been advertised. And the question is around what resilience is there whilst the recruitment, training, and induction is taking place.
Oh, right. So the post that's recently been advertised, it actually in post is one of the things we've identified. Integration and defer the faster is one of the key areas to try and achieve better outcomes and more effectively use the limited resources we have. What we found is we all know what we need to do. When you look at heads of services, directors, and the partnership between TAF and the local authorities, what we haven't had is someone then to sort of steer that work to make sure it's getting completed. So that's where there's been agreement for a regional director who will work across the 3 local authorities and Clontarf and Gannog. So they're now in post. They've had quite a lengthy induction. It's Matt Jenkins. He formerly worked he seconded from Welsh Government to support this role for a 2-year period. And one of his key roles is to develop the plan that takes it from the theory of what we want as a community model to an implementation plan. So we all signed up and have specific timescales for things to be completed. So that's in his first draft, and he's still working on the completed plan.
Okay, thanks. That's all the question. I've got a comment to make after then, Chair, if that's okay.
Thank you ever so much, Councillor Richard and Angela. Thank you ever so much for those. I did have a question, but after you explained, because like Councillor Tevye, when you were on with I didn't realise we were just looking at the professionals, so pardon my ignorance on that one, because my question was going to be, the 13%, were they the ones who just put the phone down? But my question is, the 13%, what with the 13% that weren't successful, what were the reasoning behind that? Was it unfortunately that perhaps the patient had passed, or
it could well be. They haven't given the details. It could be that when they went to see them, it's more appropriate that they are conveyed to hospital.
Yeah.
So my answer, the way they're feeding back to is that of all of those would have probably gone straight to A&E previously. And I know Clive will say that probably still doesn't feel as if they're diverting anyone, but if you look at it, it's across the 3 main sites. But then they could go and see someone and say, right, okay, from medical opinion, the right course of action is they go to A&E.
Yeah, thank you ever so much. So, comments. Oh, first of all, Declan, have you got any questions you'd like to ask on this report, please?
No, I'll put my hand up for you. Thank you, Chair.
Thank you. Right, we've got comments. So, Councillor Terry.
Yeah, I was going to say that I feel sorry for care homes. They're under a lot of pressure. They come in for a lot of criticism. And because the GP service has altered the last 20 years, it's very important to have this hub, because not long ago, loads of people used to turn up from nursing homes and die shortly after arriving, and we don't seem to get, anecdotally, we don't seem to get so many like that. When I was a GP 25 years ago, you knew all the patients in the care homes and people would phone you up for advice. They like to cover themselves, not to get involved in legal problems, and you'd give them advice. But these days, you can't get hold of the GP out of hours. And so I think it is very important that we have this hub, really, that someone will go out, really, to see them.
No, it's not a question, but I'm responding. Wynne came and did a presentation to the care home provider forum, and the care homes were really receptive to having support through that mechanism. And some of the examples saying they'd ring GP and then it might be 2 days before they did the visit, whereas in this instance they visited the same day. So they go in there making sure they have the medication. And the other area that really needs to be tightened up is around advanced care planning. So, like you say, a lot of people in the care home are being admitted to hospital just for the last days of life.
Yeah.
Where it'd be far more comfortable if they were in the care home with some additional support from, sort of community teams looking at palliative care, putting drivers in, making sure that, someone else can go in there. Because not all care homes are in the position to be able to do that and deal with some of those, the pain relief stuff. So, that's something that's on as part of that new community model. Now, do we make sure that people get the right support at the right time, Clive?
Yeah. Thanks.
Thank you, Councillor Terry. Councillor Gareth Richards.
Thank you, Chair. It's in relation to paragraph 5.4. It's just really some examples of successful interventions would be useful, perhaps for future reports.
Yeah, of course we can.
Yeah.
But I do think, sort of the 6 goals is just one element of it.
Yeah.
And certainly from the local authority point of view, the biggest area we're moving into now is looking at that integrated community model, is where that relationship between health and social care and enhancing community support to enable people to say that you'll still roll into the 6 goals. But every presentation given has been looking and focusing on the relationships between the community services as part of our model.
Thank you, Angela.
Thank you, Councillor Richards. I would just like to say thank you for the report. It was extremely interesting. I think the 6 goals, it's very welcoming, the programme for unscheduled care, and I think the service that it will provide, sitting here now, I've realised my dad received that care, and I didn't realise that. Sorry. So yeah, but reading that now, it's just like, thank you. So it's given me a better understanding, and I think it's good to know, sometimes you just don't think about these things, and all of a sudden now I understand why the GP did so much. So I welcome this report, and I wish the public would know about this programme, because when you don't know about something, it's quick enough to critique, and because people don't understand. And this, when you spoke about it and reading the report, I take my hat off. It's brilliant. So thank you for helping me understand.
In some ways, Michelle, in some ways, I think the public don't need to know all the details of the background here. What they need to know is that when they need the support, it's provided, and it's provided by the right people. So I don't. That's why I think you don't see so much these things going out in the public domain. What you see is some of the initiatives that are targeted at the public. You know, like if you look at years ago, it was Choose Well, now it's like, you know, sort of looking at going to pharmacists instead of going into, you know, going to the GP and stuff like that. So that's the messages that goes out, rather than sending out to 6 goals. If you put that out, lots of people wouldn't understand what it is, and unfortunately we couldn't explain it all.
No, I appreciate that, Angela, but I think Councillor Richards, when you just made that comment about the interventions and the success, you know, sometimes we don't need to know everything,
No.
but I think when people are aware that there is a success, and now that I realise my father was part of that success as well, it just gives you that sense of relief, you know. So it's a shame that there are certain things that can't go out to the public, and so they know that it's not only going, you know, because people just surmise. I didn't know, so it's, you know, I just think you're a hidden little gem.
Oh, I'm only a small cog in this. It's like, you know, that program is really labour intensive, and you know, there's lots of clinicians involved in there. You know, sort of Welsh Ambulance, there's a lot of people involved in that program.
Well, thank you ever so much. So we'll go on to item 4, and I will pass you over to Julia Jenkins to introduce the report for safeguarding. Thank you.
Okay, thanks, Chair. It's a Scrutiny Committee report. Report author Lisa Curtis-Jones. It's a safeguarding report, a summary of the report. This report outlines some of the safeguarding activity within Merthyr Tydfil and also taking into account the work of the Cwmtaf Morgannwg Safeguarding Board. The report outlines the work of Cwmtaf Morgannwg Safeguarding Board, whilst also highlighting some local data in relation to Merthyr Tydfil and the area of safeguarding. The recommendation, the content of the report be discussed and noted. Thank you, Chair.
Thank you. I'll hand you over to Lisa. Thank you, Lisa.
Okay, so if I just quickly go through the report. Firstly, an apology from me. I think probably remiss that I didn't compare it to sort of last year's report. When the report was requested, I wasn't quite sure of the focus of what you wanted. So I've looked at sort of the activity of the Safeguarding Board, some of the work of the reference group that we've got corporately, and then some data through children and adults, which we've recently reported to the board, because I know it was something last year you wanted something more local data as opposed to the regional data. So apologies for that. So if I've not got the right sort of areas to look at, then I'm happy to bring another report in the future if that helps. So as I've said, Scrutiny requested an update on safeguarding activity within Merthyr Tydfil. As you know, the council has a corporate safeguarding reference group where each department is represented, which we meet quarterly, and we look at various subjects around training of elected members, HR issues, any specific issues around child practice review and adult practice review where there needs to be learning and things that we might have missed, and also about raising that awareness of people bringing concerns to us. Section 4 of the report provides the updates from the Cwmtaf Morgannwg Safeguarding Board and outlines some of the work of the board and the various work streams, and you can see this is quite detailed and there's a lot of work that goes on with across the partnership. Section 5 of the report outlines some of the work of the reference group and some of the sort of hot topics that we've been talking about of late. One of those being the right to care, right person, which is the initiative through the police, which is obviously going to impact on us locally with regards to resources. Section 6 outlines the children data, looking at the children on the Child Protection Register. You can see comparative across the year, and some of the Section 47 investigations, and all that data has been presented to the Safeguarding Board and been looked at and analysed in detail in comparison to Bridgend and RCT. Section 7 outlines the adult safeguarding data. The data there is from 21-20 to 22, comparing it to 22-23, and that was looked at in detail by Zara Newman, who was within our quality assurance role at the time, and she was helping us to sort of look at the new development of the new adult safeguarding role. And I know Angela touched on that earlier, that we're in the process of recruiting to that post now. And then Section 8 obviously outlines what next. And I think the big thing to note is that safeguarding will always remain our priority, and that it is everybody's business. So it's something that's, constantly in every piece of work we do is considered when we're looking at the vulnerability of children or the vulnerability of adults. And it is something that we think about in all the work we do. So I'm happy to answer any questions if I can.
Thank you so much, Lisa. Councillor Gareth Richards.
I will come back. I've got a specific question. I'll come back to more of a statement in a second with regards to the report itself from the chair. My main wonder reading this when you were saying, what post did you say is being recruited now?
So there's the safeguarding team manager post.
Yes.
In adult services.
Yes.
We're in the process of recruiting to that now. So I think there's another interview this week. We've already done some interviews, but obviously they couldn't all attend on the same day. And then once that's sorted, we should have be able to say who's got that post next week.
Is that the same as the principal manager then?
No.
No. Is it a principal manager post?
No. So we've reconfigured that service. So
right. Yeah.
Whereas before the principal manager covered both adults and children, we've split the roles. So we've got a team manager in adult services, and then some of the duties from the children's services moved across to the principal officer within children's services.
Yeah. Okay. Thanks.
So it's given us a bit of additional capacity, if you like. So we've split the two areas.
Thanks, Lisa. Leave others ask questions. I think, Chair, that's okay. And it's something from the chair then, as a sort of recommendation, really, at the end.
No, that's fine. I can see that Councillor Salmon's got his hand up. So, Declan?
Thank you, Chair. It's just a quick one, it is. It's in regards to 4.4 and 5.5. 4.4 is suicide, but it's the self-harm reduction, which ties in then with 5.5, and you've mentioned about South Wales Police, and it's the phased approach where they're not going to do welfare checks. Has that started now? It does say February 2024. And can you give us, I know you've touched on it briefly over a couple of social services scrutiny meetings. There wasn't an awful lot of information there. You weren't given a lot of information. Do you know more now, and how it will affect everything?
Okay, so the Right Care, Right Person, I believe, goes live today. So I think it was the 26th of February. So that's phase 1. It leads us through the year to phase 4, which is probably the mental health calls. And I think that takes us into sort of the new year 25, because I think it's a period of 12 months. There's been a piece of work through the Safeguarding Board to look at numbers, about the numbers that we contact the police for welfare checks. And I guess there's also something we need to think about is the terminology we use. What we might consider a welfare check is very different to what the police consider a welfare check. So for the last couple of weeks, we've been looking at examples that if we've rung the police to say, can you do a welfare check on this? It's whether that's deemed appropriate. And some of those have turned out to be Section 47 visits, and they've needed strategy meetings. So it's about that terminology, about what we, recognise as a welfare check. So there's still a piece of work going on about the implications for us with regards to resources, but a lot of the cases that we're ringing for welfare checks are becoming sort of strategy discussions and Section 47s through discussions in the multi-agency safeguarding hub. I think we've accepted that it's happening. We can't change it. But obviously, as we get to phase 4, we'll have more information, because I think that's where the impact is going to be on the mental health calls. The phase 2, which I think goes live sort of May, June time, that will be about people going missing off from hospital settings, from potentially walking out of A&E or potentially, walking off wards. And that's something that needs to be thinking, and health are looking at that at the minute. So there are various groups that are set up under the Safeguarding Board to consider those issues.
Okay, thank you, Lisa. So really, you wanted a clear, you won't be able to see all issues until probably this time next year, really.
think probably we'll obviously look at lessons learned and we'll look at the data, but as of today, we'll start monitoring the number of calls that go into the police and those that get turned down, and those that get accepted for visits, if you like. From the information the police have given us, and the examples they gave us, then some of the welfare checks have been turned down for the right reasons, because they weren't appropriate. They were things that we should have been doing, and not just we as social services. I mean, generally other professionals that the police are contacted when, it's not necessarily their job to do it. We're very lucky in Merthyr. We've got an outreach team and they do a lot of our welfare checks. So I guess for the phase 1, it wasn't going to be too much of an impact on us. So if we've got a family we're concerned about, then outreach may go out and do that drop-off visit at 6 o'clock in the evening, just to do that welfare check and check that things are okay and be a point of contact. That isn't a police role at all. And it's moving away from that, really.
Okay, and just quickly, when you get a chance, I know you're really busy, would you be able to give members just a little breakdown of exactly what phase 1 is, phase 2, phase 3 and phase 4, just so that they're aware at some stage?
Yeah, I can forward the presentation and slides that we've had to members so you can see that.
Okay, thank you, Lisa. Thank you, Chair.
Thank you, Councillor Salmon, and thank you, Lisa, for that. It'd be much appreciated if you could forward that to us.
Any other questions?
Yeah. Sorry, Councillor Gareth Richards.
You went about a foot lower then.
I know,
Chair.
I'm feeling going down. Sorry.
Lisa, you did touch on it. I think when you spoke, really. I understand this report came about as a result of a report being presented to committee in June, which unfortunately I wasn't at. But the comments I've had via the chair is it's not as perhaps was expected. And she has requested it, if we can fit it in the cycle, if a further report can be brought back within this cycle. And what I would suggest, obviously, is the chair sits down with you to outline in detail what she feels hasn't been covered.
Yeah, that's fine. I mean, the remit of me, really. So, because obviously the information I had was safeguarding report, and I assumed it was the annual report you wanted.
Yes. Yeah.
So, yeah, if the chair wants to sit down with me, we can look at that.
Yeah. Okay. Thank you. Thank you, Chair.
Thank you ever so much. So, any more questions? So we'll go on to comments. I'll just make a comment. Safeguarding means a lot to me, it's part of my job as well. So I welcome the report and I welcome everything that, you're all doing to strengthen safeguarding and bring forward safeguarding to and safeguarding our constituents, the children and adults. So I'll just say thank you ever so much on that one. So thank you. So we'll go on to item 5, which is the forward work programme. I don't think there's what's on the forward work programme.
The latest version. Do this year, the neighbourhood.
Yeah, so we've got there was the neighbourhood learning centre visit. Unfortunately, it appears that we're all unavailable on the 12th of March. So I'm just wondering if we can possibly share another date with us, or if we could have maybe 2 dates that we could have a look at.
Is it a better date?
Yeah,
all the dates were on a Tuesday.
Yeah, they were all on a Tuesday. I mean, I struggle sometimes with my schedule, but if we could try and agree on another date for that would be appreciated, please.
It's Tuesday, 8 till 2. That's the trouble.
Tuesdays are difficult for me as well, so.
Okay, so if we could just not look at a Tuesday then, that would be appreciated. Thank you so much. So item 6, scrutiny referrals. There's no referrals have been received at this stage. Item number 7 is report recommendations.
Just noted the reports and we'll take the comments back on the safeguarding report.
Yes, what Jane just said, so we've noted that and we'll take them back. So do we agree with the recommendations? And yeah.
Yes, Chair.
Thank you very much. Item 8 is feedback on scrutiny activities. So we had received a report from the conference Snakes and Ladders, which was circulated as agreed to members on the 14th of December. Agreed to hold visits until next cycle, and I have to say I'm quite looking forward to that visit. So I do hope that I can attend that. That date then for the NLC, which we couldn't do, and I don't think there isn't anything else. Or is there anything that any of my fellow councillors think that we would like to do as a scrutiny activity? Visit? No, that's that. Item number 9, any other business? I haven't got any, so I would like to say thank you to the officers and Cabinet Julia Jenkins for attending, and we'd like to leave. You can stay if you want and chat with us. So
Yeah, I might just have a Right, thanks. Yeah.
Thank you.